All right, let's jump right in. We're going to tackle one of the absolute cornerstones of medicine, the abdominal exam. It can seem super complex, right? But don't worry. We're going to break it down into a really simple 4-step process. By the end of this, you'll know exactly how to walk in there and nail it, every single time.
So, picture this. You walk into the exam room, your patient looks at you and says, "Doc, I've got stomach pain." Man, that is probably one of the most common things you're ever going to hear. But it's also one of the vaguest. So, where do you even start? I mean, stomach pain could be anything from, bad takeout to something really, really serious.
Well, the answer is actually pretty cool. You have to think of yourself as a detective. The abdomen is telling a story, and your job is to uncover the clues. But here's the catch. You have to follow them in a very specific order to solve the mystery. So, let's get into it. Let's learn how to read this story.
Okay, so here's something that might surprise you. The most important part of this whole exam, it happens before you even lay a hand on the patient. Seriously, it's all about setting the stage for success. You've got to create the right environment and listen, really listen to what the patient is telling you.
First things first, you just listen. This is where you gather all that key subjective data. What exactly is their chief complaint? Tell me about the pain. Have they had any past issues, like ulcers or surgeries? What about their family history and their lifestyle, things like diet, alcohol, stress? Every single answer they give you is a piece of the puzzle. It helps you zero in on what you're really looking for during the physical part of the exam.
All right, next up, you got to get the room and the patient ready. Make sure the room is warm and has good lighting. Nobody likes being cold and exposed. You want to ask them to empty their bladder too, just for comfort. Then get them to lie flat on their back, what we call supine, with their knees bent just a little bit. This is great because it helps relax those abdominal muscles. And here is a huge pro tip, you guys. Always, always ask if they have any painful spots. Whatever they point to, you save that spot for the absolute very end. Why? Because if you press on a sore spot first, they're going to tense up. We call that guarding. And boom, the rest of your exam is basically useless.
Okay, the stage is set. We've got the backstory. Now we can finally get to the main event, the hands-on exam. And it breaks down beautifully into 4 simple steps. Just think. Look, listen, tap, and press. Now, the fancy medical terms for these are inspection, auscultation, percussion, and palpation. And I cannot stress this enough. That order is absolutely non-negotiable. You have to do them in that exact sequence to get a good exam.
So you're probably asking, okay, but why? Why does the order matter so much? And that's a fantastic question. The answer is honestly one of the biggest takeaways from this whole thing. Here it is. If you start poking and prodding the belly first, that's the tapping and pressing, you can actually wake up the bowels. You can make them gurgle and make sounds that weren't there naturally. You're basically creating false evidence. So we always listen first before we touch so we can hear what the abdomen is really doing in its natural state. That's how we get the true story.
Okay, let's kick it off with step 1, inspection. This is just you using your eyes. No touching yet. You're just taking it all in. What's the overall shape or contour? Is it symmetrical? Do you see any scars, any stretch marks, we call those stria, or any rashes? And then look for movement. You might actually see the aorta pulsating, especially in a thinner person, or even waves of peristalsis, which is the intestines doing their thing.
Just the shape alone can tell you a ton. If you see a scaphoid abdomen, that's one that's kind of sunken in and concave. It might make you think about malnutrition. On the other hand, if it's protuberant, rounded and bulging, that could just be extra body fat, sure, but it could also be a red flag for something like ascites, which is fluid building up where it shouldn't be. All right, step 2 is auscultation. Time to break out the stethoscope. You're going to use the diaphragm, the flat side, to listen for those higher-pitched bowel sounds. And here's the convention. We always start in the right lower quadrant, the RLQ. Why there? Well, that's where the ileocecal valve is, so it's usually the easiest spot to hear some action. And hey, we're not just listening for stomach gurgles. After you've listened for bowel sounds in all 4 quadrants with the diaphragm, you're going to flip your stethoscope over to the bell. Now you're listening for vascular sounds. Specifically, you're hunting for something called bruits. That's a whooshing sound, and it means there's turbulent blood flow, maybe from a narrowed artery. You want to listen for those right over the aorta and the renal and iliac arteries. So what are we listening for exactly? What's normal? Well, the magic number is somewhere between 5 and 35 gurgles per minute. If you're hearing way more than that, we call them hyperactive. Way less, hypoactive. And if you put your stethoscope down and hear nothing,
Absolute silence? You can't just move on. You have to listen for a full 5 minutes before you're allowed to say that bowel sounds are truly absent. That's a big deal.
Okay, moving on to step 3, percussion. This is the tapping part. You're basically tapping on the belly to hear the different sounds it makes. Think of it like tapping on a wall to find a stud. Over the parts filled with air, like your intestines, you'll hear this hollow, drum-like sound. We call that tympany. But when you get over a solid organ, like the liver, that sound changes to a dull thud. Totally different.
And this tapping technique is super useful for estimating how big the liver is. Here's how you do it. You start down low in the right lower quadrant where it's all tympanic and drum-like, and you tap your way up until, thud, it turns dull. You mark that spot, that's the bottom edge of the liver. Then you go up to the chest where the lungs sound resonant, and you tap your way down until that sound turns dull again. Mark that spot. The distance between your two marks, that's your liver span. Pretty neat, right?
And finally, we've arrived at step 4, palpation, or pressing. And just like the main sequence, there's an order here too. We always start with light palpation first. We're just gently pressing down, maybe a centimeter, feeling for any tenderness or that muscle guarding we talked about. Only after we've done that everywhere do we go back and do deep palpation, pressing down further about 4 or 5 centimeters to really feel for the organs and any deeper masses.
Okay, so you've done the basic 4 steps, but what if the patient's story or something you found makes you suspicious of something specific, like appendicitis or a gallbladder problem? Well, that's when you bring out the special moves. These are like your advanced detective techniques to really nail down the diagnosis.
First up, if you're thinking gallbladder inflammation, what we call cholecystitis, you're going to check for Murphy's sign. What you do is you gently press your fingers under their right rib cage and ask them to take a big, deep breath in. Now, if their gallbladder is inflamed, as they breathe in, it's going to get pushed down right onto your fingers, and ouch. They'll feel a sharp pain and stop breathing in abruptly. That little gasp, that's a positive Murphy sign.
Now what about appendicitis? A classic test for that is the psoas sign. It's really simple. You have the patient lie down, and then you ask them to lift their right leg up while you provide some gentle resistance, pushing down on their thigh. See, this action engages the psoas muscle, and that muscle happens to lie right near the appendix. So if the appendix is all angry and inflamed, that movement is going to cause pain right in that right lower quadrant.
And remember that bulging, protuberant belly we talked about? If you think it might be from ascites or fluid, you can test for shifting dullness. It sounds complicated, but it's not. First, with the patient on their back, you percuss. You tap to find the line where the dull sound of the fluid meets the hollow sound of the bowel. Then, you have them roll onto their side, and you do it again. Because fluid follows gravity, that line of dullness will have shifted. It's a really clever way to confirm there's free fluid sloshing around in there.
So, you've done all this amazing detective work. You've gathered your clues, but you're not done yet. There is one last absolutely vital step. You have to write it all down. You have to document everything, because in medicine, if you didn't write it down, it didn't happen. And a good note is clean, it's concise, and it follows the exact order of your exam. For a totally normal abdomen, it might look something like this. See how it's specific. It doesn't just say bowel sounds present, it says 16 per minute. It gives an estimated liver span. It's descriptive, soft, non-tender. This is what you're aiming for. This is the gold standard. And there you have it. We've gone through the whole thing, from setting the stage all the way to writing the final report. You now have the roadmap to confidently read the story that every abdomen is telling. So the only question left is, the next time you walk into a room and hear stomach pain, what's the first clue you're going to be looking or listening for?